Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 220 of our pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, T.O.A. A pregnant woman is found to have a positive RPR and negative FTA-ABS on routine prenatal screening. T.O.A. has a history of anaphylaxis to penicillins. So my question to you is, what is the most appropriate treatment for T.O.A.? Is it A, azithromycin, or B, ceftriaxone, or C, doxycycline, or D, levofloxacin, or is it E, penicillin, following allergy desensitization? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E, penicillin, following allergy desensitization. I will explain why. Penicillin is the preferred treatment for pregnant women with syphilis, as it is the only agent with well-documented efficacy in preventing congenital transmission. Please proceed to the next question. And the next question reads, NOW, a 23-year-old man with a history of recurrent methicillin-resistant Staphylococcus aureus skin abscesses, but no other past medical history, presents with invasive aspergillosis. So my question to you is, which enzyme or pathway derangement would cause a primary immunodeficiency that could be characterized by infections with both of these organisms? Is it A, CD18, or B, IL-12, or C, MPO, or D, NADPH oxidase? Or is it E, STAT3? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, NADPH oxidase. I will explain why. Chronic granulomatous disease is caused by defects in NADPH oxidase. Characteristic infections seen in patients with CGD include Staphylococcus, Serratia, Burkholderia, Chromobacterium, Nocardia and Aspergillus species. Please proceed to the next question. And the next question reads, with which of the following syndromes listed below are eosinophilia, eczema, characteristic facies, chronic mucocutaneous candidiasis and recurrent pulmonary infections typically seen? Is it with A, Chediak-Higashi syndrome, or B, chronic granulomatous disease, or C, Jobs syndrome or HIES, or D, leukocyte adhesion deficiency type 1? Or is it with E, Wiskott-Aldrich syndrome? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, Jobs syndrome or HIES. I will explain why. Jobs syndrome or hyper-IgE syndrome, abbreviated as HIES, is an autosomal dominant disorder characterized by recurrent infections, typically of the respiratory tract and skin, high levels of IgE, peripheral eosinophilia, characteristic coarse, facies, eczema, chronic mucocutaneous candidiasis and abnormalities of the connective tissue, skin and teeth. Please proceed to the next question. And the next question reads, abnormalities of the IL-12 IFN gamma pathway can cause increased susceptibility to infection with what organism? Is it A. Aspergillus fumigatus, or B. Candida albicans, or C. Mycobacterium tuberculosis, or D. Pneumocystis jirovecii, or is it E. Staphylococcus aureus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Mycobacterium tuberculosis. I will clarify why. IL-12 IFN gamma pathway defects increase risk of TB and non-tuberculous mycobacterial infections, salmonellosis and some viral infections. Please progress to the next question. And the next question reads, RPR, a 46-year-old woman with neutropenia following hematopoietic stem cell transplantation for acute myelogenous leukemia has been febrile for 5 days despite broad-spectrum antibiotic therapy. A CT scan of RPR's chest, abdomen and pelvis is obtained. Carefully scrutinize it before answering this question. Pause the video at this stage and carefully scrutinize the CT scan before answering question in the next slide. What infection is the most likely cause of RPR's symptoms and imaging abnormalities? Is it A. Aspergillus species, or B. Candida species, or C. Pseudoleishmania boydii, or D. Pseudomonas aeruginosa, or is it E. Stenotrophomonas multifila? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Candida species. I will justify why. She has disseminated candidiasis as manifested by multifocal nodular lung lesions and multiple hepatosplenic abscesses. Multiple septic emboli from a bacterial process could also be considered given her multifocal pulmonary and hepatosplenic lesions. Please proceed to the next question. And the next question reads, RWT, a neutropenic patient develops fever and progressive, necrotic skin lesions on his lower extremities. The photo below is a representation of this clinical scenario. Pause the video and scrutinize it carefully before answering the question in the next slide. Blood cultures are obtained and RWT is started on broad-spectrum antibiotics. A few days later RWT's blood cultures are showing fungal elements. So my question to you is, what is the most likely cause of RWT's skin lesions? Is it A. Aspergillus, or B. Candida, or C. Fusarium, or D. Histoplasma, or is it E. Nocardia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Fusarium. I will clarify why. Bacterial and fungal infections can cause disseminated necrotic lesions in neutropenic hosts. In this patient with concomitant fungemia, Fusarium is the most likely cause of his symptoms. Please progress to the next question. And the next question reads, which scenario and combination of donor and recipient CMV serostatus would put the recipient at highest risk for post-transplant CMV disease? Would it be A. HSCT, donor CMV negative, recipient CMV positive? Or B. HSCT, donor CMV positive, recipient CMV negative? Or CHSCT, donor CMV positive, recipient CMV positive? Or D. Solid organ transplant, donor CMV negative, recipient CMV negative? Or would it be E. Solid organ transplant, donor CMV positive, recipient CMV positive? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. HSCT, donor CMV negative, recipient CMV positive. I will clarify why. For HSCT recipients, the highest risk for CMV disease occurs when the stem cell donor is CMV negative and the recipient is CM positive. In solid organ transplant, the reverse is true. Please proceed to the next question. And the next question reads, a renal transplant recipient is found to have tubulointerstitial nephritis and blood PCR testing that was positive for a polyomavirus. What manifestation does polyomavirus also cause in HSCT recipients? Is it A. ecthyma gangrenosum, or B. hemorrhagic cystitis, or C. leukocytoclastic vasculitis, or D. post-transplant lymphoproliferative disorder? Or is it E. progressive multifocal leukoencephalopathy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Hemorrhagic cystitis. I will explain why. Reactivation of BK virus in kidney transplant recipients can cause tubulointerstitial nephropathy and ureteral stenosis, whereas in HSCT recipients it can cause hemorrhagic cystitis. Please proceed to the next question. And the next question reads, UMK, a middle-aged man with history of splenectomy because of idiopathic thrombocytopenia purpura presents to the ER with sepsis, gangrene and purpura fulminans following a dog bite as shown in the photo below. Pause the video and carefully scrutinize the photo before answering the question in the next slide. What is the most likely cause of his sepsis? Is it A. Capnocytophagia canamorsis, or B. Eikenella corrodens, or C. Neisseria meningitidis, or D. Pasteurella multocida, or is it E. Staphylococcus aureus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Capnocytophagia canamorsis. I will justify why. Capnocytophagia should be considered in a patient presenting with sepsis following a dog bite. Risk factors include alcohol abuse, cirrhosis, immunosuppression and splenectomy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 221.